And we decided to do a little different presentation today, as Marie addressed a couple of the basic things with lung AVMs. And we're going to have a couple cases to start as well. And first, our conflict of interest slides. And a quick review of the prevalence, which Marie addressed, and it's in the guidelines. The North American HHT estimate is 1 in 500. So we worked with Alberta Health, our Ministry of Health, to look at a stroke registry that's province-wide for everyone with Alberta healthcare number. And using data capture in different realms, working with our stroke neurologist, Dr. Ajira, we found a prevalence rate of 1 in 3,800, so higher than North American estimates. That's important when we crunch the numbers for how many patients who may or may not have been seen in an HHT center, maybe walking out there with brain AVMs, lung AVMs, etc., with treatable manifestations if they're actually seen. And many of you know, most HHT patients have not been seen in an HHT center. So in Edmonton, we have a preponderance of females. This is just a quick slide to show our local statistics, which we present to Alberta Health Services every couple of years. And there's different reasons for that, but also with our prevalence study, we looked at stroke complications. And it seemed that females with HHT in our population had a higher prevalence of strokes compared to males, slightly higher. And the majority of these are from pulmonary AVMs. So going into thoracic manifestations, most are familiar with pulmonary AVMs. They can be single, multiple, complex, diffuse PAVMs. And the treatment can be quite fidgety. So I'll let Richard talk to that aspect. Pulmonary hypertension is also seen with higher prevalence in HHT, and especially as someone gets older. Some of the techniques we use for pulmonary AVMs can also be used to indirectly measure pulmonary pressure, pulmonary vascular pressures. And if needed, they go on to further assessment. Of course, there's also cardiac manifestation, and Marie already spoke to that. High output heart failure from systemic AVMs is seen in a smaller proportion of patients. But we'll focus today on pulmonary AVMs. So the first case is a 64-year-old male who presented as an inpatient. He's a recent immigrant to Canada, large family. He had headaches, confusion, he was hypoxic on room air, never smoker. The HHT team was consulted by the neurosurgeons post-operatively. So when we look back, he had a CT of his chest 2 years earlier that showed a large lung AVM. But it was done for a different reason, different indication, and I guess it was forgotten about. So I will let Richard take over at this stage.
Okay, hoping you can hear me okay. So yeah, the two images on the right, the one on the top is a CT scan and the one on the bottom is an MRI, and they're in a different projection. But one good way to look at x-rays is to look at symmetry. You know, when you look at cross-sectional imaging, often the body is symmetrical. So you can see there that, you know, on the left-hand side of the brain, you can see there's a black dot, which is not, there isn't one on the other side. And around that black dot is some sort of diffuse dark area. And that's consistent with an abscess with surrounding edema in the brain. And of course, that causes a lot of brain dysfunction and you know, confusion, and that's why he had a headache. And the MRI at the bottom just really shows the same as the CT. So as Dilini pointed out, on his chest x-ray had an AV malformation. So if we move on to the next slide, Dilini, you can see, so this is a catheter angiogram, and Marie showed one earlier. The black line running through the middle of the image in a snake-like orientation is the catheter that is coming up from the femoral vein, up through the right side of the heart, through the pulmonary artery, through the pulmonary valve, through the pulmonary artery, and then it's up into the upper aspect of the right lung. And you can see that the end of the black tube, there's an artery which is enlarged. And then it's kind of dividing into multiple small veins. Now it looks a little different from the one Marie showed. And the reason it looks different in this case is because what probably happened in him is his pulmonary AVM became infected. So it became, full of infected blood clot. And then one of those pieces of infected blood clot broke off. And it's kind of very, very important, this whole concept as to why we're worried about the pulmonary AVMs. We're worried because they're a direct communication between the right-sided circulation and the left-sided circulation. And in normal people, there's two circulations which are separated by tiny capillaries, which is the right side and the left side. And in everybody, when you clean your teeth, for example, you do get some bacteria that come from your gums, and they'll come into your bloodstream, and they come into the right side of the bloodstream, and most of them will get filtered out. In normal individuals, all of them will be filtered out within the lung, and they'll get stuck in tiny capillaries, and they'll be just dealt with by the body. The problem is if those infected or bacteria get stuck in something abnormal like a pulmonary AVM, then they can cause infection, or they can shoot all the way through the lung. And now they're in the left side of the circulation. And that's the side of the circulation that supplies your arterial circulation to your brain, to your kidneys, to your heart, to your peripheral body. So that's likely what happened in him. So, and then of course, what we need to do is we need to block off this AVM to try and reduce that risk. And that's what we do. And as Marie again pointed out, pulmonary AVMs are fairly common. So we do this fairly frequently. Over the years, I've done more than 100 cases like this. And then, we use a number of devices, but it's really very simple conceptually. You have to get a catheter right up to where the sort of short circuit is, and you have to block it off. And what we use depends on how big it is. The bigger ones need a bigger device than the smaller ones. And these on the right, just go back one shot there, Dilini, sorry. Go back one slide. On the right-hand side, you can see I've kind of dotted an outline. There's actually 3 devices in that big artery, and it is really magnified. This is probably about 8 millimeters in diameter, so still quite a big blood vessel, but there's 3 plugs in there. So if we move on, Dilini again. So one of our very favored devices is called a vascular occlusion plug. And it's a very nice device. Very well designed, and it comes on the end of a wire. And the nice thing is, so what you do is you put it in a tube, in a thin tube that's all the way to where you want to deliver it. And then you push it gently out through the end of the tube, and it pops open. So into its sort of unconstrained, comes small and pops open to a bigger size. And then actually at that point, because it's still on the end of the wire, you can think about it and say, oh, I think this is too small, or maybe even this is too big. And you can actually pull it back into the little catheter, and you can actually take them out. Or you can do a little angiogram and say, this looks great. And then it's sort of screwed on the wire, and you just unscrew the wire from the outside of the body, and then you unscrew the connection. And there's 3 or 4 different types, and they have multiple applications, many of which are not in HHT. So people with a hole in the heart, for example, a shunt between the left and the right side of the heart, which many people are aware of. These are what I use now to occlude those in cardiology. In the peripheral body, we use them also for other aneurysms and other bleeding disorders and other problems we have. But they're a nice little device, and they've kind of, in the original, Bob White, who was the original interventional radiologist who really pioneered nearly all of these treatments, didn't have these devices available to him back in those days. So he devised a number of elegant techniques for treating these. The nice thing with these is that because they're on a wire, they can't fly off and go in the wrong place, or certainly not. It's much less likely that they will do that. You know, the original devices with coils were harder to be accurate with. So I think that's all I'm going to say. And I think, Dilini, you're going to move on, correct?
Yeah, just a point there. So coils, plugs, sometimes some other methods are used. So it's very technical. So having someone who is familiar with the pulmonary circulation and therapeutic embolization is very, very important. So these patients with pulmonary AVMs have a shunt, and shunt is not, as many patients of mine have heard, it's not a medical thing alone. We use it in agriculture. It's just talking about diversion of flow. So if a farmer wants to water a field, they may redirect a ditch in a certain direction, irrigation. But in the body, there's different types of shunts. So redirecting fluid can be a surgical shunt, like some of our neurosurgeons will put in a ventricular peritoneal shunt. Some of you may have heard. There's cardiac shunts, as Richard mentioned, a hole in the heart. Most people are familiar with someone who's had an atrial septal defect or ventricular septal defect in childhood and has had surgery for these. Most times in childhood, but not always. But here, what we're looking for is a pulmonary shunt. So we've talked back and forth with they should say cardiac or pulmonary, sorry, I missed a word. Back and forth with the cardiologists and specifically echocardiologists when we started off to say, well, how can we better differentiate an intrapulmonary inside the lung shunt from an intracardiac shunt? So since we started, Dr. Jonathan Choi has been a few months after we started, Dr. Choi has been the echo lab lead at the Mazankowski Heart Institute, and this video is courtesy of him. We do the echoes, we look at the pulmonary veins, because of course, if it's an intracardiac shunt in the heart only, it won't necessarily show flow or bubbles with the technique that's used coming through the pulmonary veins that empty into the main left side of the heart that pumps out to the body. So Richard's used the word right heart, left heart. So all of us have 4 chambers, 2 in the right heart, the right atrium, right ventricle, and left atrium and left ventricle. So the left atrium gets all the blood from the lungs through the pulmonary veins, pushes it down into the left ventricle, and it goes out to the body. So that flow, that pathway is very, very important. We also grade the echoes. So if they have a shunt, is it a small shunt? So grade 1 or grade 2 echo, or is it a larger grade 3 or very large grade 4 shunt? So if it's not a grade 3 or 4 shunt, sometimes we may not see anything from the anatomic assessment of a patient, x-rays, even CAT scans, but you'll see it on the physiologic measure, which is the contrast echo or agitated echo or bubble echo. These are different terms you'll hear. So pulmonary AVMs can cause different sorts of complications. It can even be asymptomatic, meaning no symptoms whatsoever, and that's actually the most common finding. And some people will have shortness of breath on exertion, often misconstrued as asthma. So my original fellowship was in asthma at McMaster. So for different reasons, bringing those 2 areas together, we're often removing inhalers from patients who don't need it and for many years have thought they had just asthma. Fatigue, that's common in patients, along with clubbing, bruits, which is a sound we hear with the stethoscope, or pulmonary murmurs is another term. And we've had a few where they have large pulmonary AVMs. You're listening with your stethoscope over the lungs and you hear a lung murmur. It's great for medical students and residents. After we embolize it, then that murmur is gone. Migraines common. Some patients, a few of them will actually say, my migraines are getting worse. I think my pulmonary AVMs are growing. Often I've had, maybe 4 or 5 people who can actually predict ahead of us where this is the case. Hemoptysis or coughing up blood. I think Marie also mentioned, or someone mentioned, pulmonary hemorrhage. So if pulmonary AVM ruptures, it can be deathly. Spontaneous hemothorax. And we've actually had that, a lady who wasn't followed in our center. I actually got a call from one of the ICU docs in a smaller hospital here in Edmonton to say this lady came in late in pregnancy. And this was her 10th child. She came in and they found that she had a ruptured pulmonary AVM. She passed away. So it's not benign, but these are preventable complications. We've already mentioned strokes or transient ischemic attacks, TIAs, brain abscess. Those are the ones you hear of most: strokes, TIAs, brain abscess. And of course, death, which we never want to see from this. So there's a higher mortality in some subgroups, including those with PAVMs. So ideally, you want to have pre-symptomatic testing, assessment in an HHT center, but also molecular genetics, as Marie pointed out. Some exciting news from Alberta. We used to send our blood out of province, out of country for molecular genetics. Since September 1st, with a lot of bugging for many years, we've been able to start doing testing in-house within Alberta Health Services through the Alberta Precision Lab, they call it APL. And they use a newer technique. So working with our geneticists in Calgary and Edmonton, we have a standardized process for doing this. So it makes it much quicker, much easier. And actually it's less costly, hugely less costly for patients to have testing in-house. In the past, we've had some people actually refuse testing from Northwest Territories or other places where the testing is so expensive in the old days. It wasn't easy to get everyone funded. So this is an important step from last September that we have it in-house. So once we know a patient has possible or definite HHT, we do screen for pulmonary AVMs. This initially involves a standardized bubble echo with the same day chest x-ray. We still do that. Sometimes patients forget to do the latter. And as long as we have an imaging within a short period of time, that's fine. And as I mentioned here, we differentiate intrapulmonary and intracardiac right to left shunts, or RLS. So those who don't have a biology or physiology background, that might be a very difficult concept. And we have a nurse in clinic who spends quite a bit of time teaching patients about pulmonary AVMs so they understand health literacy. It's very important, like Rose is doing in Toronto, and I guess now Beth. So standardized bubble echo is important. I have many patients who've gone to peripheral echo labs. We have a lot in Alberta. That's not standardized. It doesn't give the information we want. And when we talk about a single payer system in Canada, that's important. Do it right the first time, and make sure we get the appropriate information. Also, if the echo isn't in an accredited lab that is doing these, so not outside of hospital labs, ideally, and we've had many, it's important that the person in that lab who's doing the study knows how to do a standardized algorithm of assessment, reporting even, because that we use for a lot of information, especially in their baseline study. Happy to answer more questions on that, but I will just say most echo labs in Alberta, Western Canada are not standardized. So it had to go through an accreditation process, which all HHT centers have to go through prior to the lab being approved. CT chest we only reserve when we're planning for therapeutic embolization. If an echo is negative for a shunt, we don't necessarily proceed to that. Especially important in kids. I think Dr. Majasic, our PEDS HHT lead, is here, and we've talked a few times about radiation exposure. So we want to try and minimize, even with low dose CTs, low dose radiation. Things that we can avoid, and HHT patients get a lot of radiation induced imaging. Therapeutic embolization, for the most part, is done in asymptomatic PAVMs with feeding arteries over 3 millimeters. However, we've had a few situations where we treat smaller feeding arteries, and we're getting into smaller and smaller feeding arteries with symptoms. And Dr. Owen can speak more to microcatheters. So the IR suite that it's done in and the equipment they have is very important as well, not just the person. So if we run out of this or we don't carry this, smaller centers, I think that's more important in more rural areas. And I call Alberta a rural province. Saskatchewan is a rural province. It's doubly important you get it done in the right place. This, I'm sure most of you are familiar with, but HHT centers, what's required? We need a dedicated interventional radiologist. We need a respirologist, or sometimes a hematologist, like Dr. Kasturi, who's going to be talking to, as the point person, and an echocardiologist, ENT, liver or hepatologist, subgroup of gastroenterologists, genetics, geneticist, genetic counselor. Although in Alberta, respirologists who are dealing with HHT can, and I do order molecular genetics with the counseling on some cases myself. Neurologists, neurosurgery, neurointerventional radiology, the brain team. And the neurologists, they have subgroups nowadays, so specifically a stroke neurologist. Pediatric team, including pediatric neurologists and obstetrics, obstetrical medicine, and perinatology. But if we don't have an IR, it's someone who understands the pulmonary circulation. It's very difficult to get all the different aspects done. So yeah, I will pass it on to Richard.
Okay, thanks, Dilini. So, one of the questions we're kind of asked is, and that it happens in Alberta is, why do I have to go to Edmonton? Why do I have to go all the way to Edmonton from, Grand Prairie? Grand Prairie has the CT scan and MRI scan and has, radiologists. So, part of that is actually on the previous slide. It's the HHT centers have a whole list of people that are knowledgeable in HHT. And, when we're doing a procedure, we sometimes need those people. We may need them before we do the procedure. We may need them when we're doing the procedure in rare cases. So, the reason that you need dedicated people and people with experience, and experience only comes through doing cases. It's not a matter of age. It's due to doing cases, talking to hematology, having a patient who's anticoagulated and then you don't know what to do, having a patient with bad migraines and then you call neurology, having a patient with a cardiac history, speak to someone in cardiology. And I've done all of those things, as I'm sure many of the physicians involved in HHT care have done. So, and the procedure starts before the procedure. So, I'll look at the imaging. Dilini and I will often go over the imaging and decide what we're going to do. But I'll look at the imaging, I'll make sure that I know what I'm doing, how I'm going to do it, what equipment I need, and do I need to speak to hematology? Do I need to speak to cardiology, neurology, etc.? And then, so, that's the reason that you come. Now, some of the straightforward cases are relatively simple, and in emergency situations, they can be done by many interventional radiologists. But the problem comes is to try and reduce the risk. And we know that risk reduction comes with doing these things during the working day, good planning, good forethought, having the right people around if you need them, etc. So, that's kind of why we make such a big deal of this, because this is a routine procedure and it should have absolutely low risk as we can possibly achieve. And one of the, so everyone will say we're doing this to reduce your stroke risk, let's say. So I don't know that many people probably have somebody who's on warfarin or rat poison for atrial fibrillation. So atrial fibrillation is when one of the 4 heart chambers, the right atrium, is not contracting properly. So instead of contracting rhythmically, it's just kind of vibrating. It's not, and what that means is that within that chamber some of the blood is relatively stagnant. So those patients get anticoagulated, because if not, blood clot can form in the atrium, and then it can form an embolus and form a stroke. But the risk of that happening is very tiny per day, even without anticoagulation. So it's minuscule per day, but if you add up days to weeks to months to years, your risk of having a stroke, and the same in pulmonary AVMs, just goes up. And that's how I explain it. So when we do an embolization, we're trying to reduce the long-term risk of stroke. But the risk of stroke on that very day during that procedure is it's not high, but it's definitely a risk. So that's the biggest thing we fear, is causing a stroke on the day of the procedure, and which is why we need all that experience. Anyway, let's move on to the next slide, Dilini. So, my technique is, as I've already pointed out, you've got to get as close to the actual abnormal telangiectasia, the bit at the end of the blood vessel, as Marie pointed out. You want to get to the end. It's no good embolizing it at the beginning. It's not going to help. The advantage of embolization over earlier surgical techniques is we can preserve nearly all of the normal lung. We can do this without embolizing any lung in many instances. And because, of course, you need your lung, and you want to preserve as much as possible. Particularly in patients with 30 or 40 pulmonary AVMs, we have to preserve lung. And so that's the advantage. Some things that you have to think about. So if you do embolize a little bit of normal lung, you can get a cough. You can get a little bit of pleuritic chest pain after the procedure. It's not necessarily a problem, but it's something to be aware of. And then, we've got to be absolutely scrupulous. We call it an underwater technique. It's not actually a scuba diving technique, but it's still an underwater technique, in that, we can't have any air going in. If we let any air into this pulmonary AVM, it's like we pointed out earlier, it's going to suddenly find its way into the left-sided circulation. And it's going to maybe cause a little stroke or a short-term neurological problem. Or sometimes I think it can precipitate migraines. And the other thing is, like Dilini talked about equipment, we need really good equipment. You need a good angio suite. There's nothing worse than working on an old piece of equipment that you can barely see. And a lot of smaller centers, that's really all they have because of the cost involved. These angio suites are $2 to $3 million each. So they're not situated in the smaller hospitals. So if we go on to the next one, Dilini. So we've all seen the ones that Mary showed with the big blob at the end of the blood vessel. This is a little bit different. This is actually a patient who's been previously coiled. So you can see that nest of black sort of lines is actually a series of embolization coils. But on the right-hand image, you can see that, in fact, there's 2 blacks. Can you point the squiggles out, Dilini, distal to the coils? So in the bottom left of the picture, there's little dark squiggles, which is actually contrast that's flowing through the coils. Now that's not supposed to happen when we put coils in. The whole concept is we'll block the vessel off. So we can, that can happen due to two reasons. One is maybe the coils weren't put in, you couldn't get them packed enough. Maybe they weren't quite close enough to the actual AVM, because there's actually two AVMs here very close to each other. Or maybe some individuals are more prone to this type of problem. But in this case, and I'm sure Dilini remembers this gentleman very well, he is very, very prone to these transient ischemic attacks, or TIAs, which are minor neurological events that occur and go away without leaving a stroke. And he also had pretty bad migraines, if I recall. So we went in there and we had to do some other techniques. But sometimes, when we get patients who've been treated sort of in other centers, we find that they've been coiled, but they haven't been coiled sort of adequately, or they didn't have the equipment likely, or, they just were doing it the best they could. So that's another thing to kind of be aware of. So do you want to move on? What's the next slide? I can't remember now. Yeah, so in this case, what we did is we put one of those little Amplatzer plugs in. We were lucky enough, had a little bit of room before a bit of lung was being supplied, and we could put that little, you can see that little pear-shaped plug in the left-hand image just past the catheter, and we were able to block off the vessel adequately. We can do this sometimes. We can't always achieve a good result here, but we managed it in this case. Could you go to the next slide too? So, this is a bit complicated, but it's really just to outline that, we need a whole variety of things. Not everybody is the same. One patient, I had to use a 16 millimeter plug-in. So 60 millimeters is the size of your thumb. So that's a pretty big medical device. And some of them are 1.5 millimeters. So obviously we need a different device for those small ones. We need to use different catheters, different guide wires. And, sometimes the one catheter doesn't work and we need a different catheter. So, you do need a big inventory of equipment. And being a center that also does neuro, which most of the HHT centers have a combination of both expertise on site. So we do sometimes use the neuro expertise to get to where we want to go to. So I'm not going to go into that. And then, do you want to do the follow-up, Dilini?
Yeah, sure. I'll take over here. And I'll say that when we started off, there's a Richard Owen and there's another gentleman named Rob Ashford, who's still around, trying to retire but can't. And he's a neurointerventional radiologist. We had both Richard and Rob do a few cases together because these can be quite complicated. In some ways, more complicated than peripheral embolizations outside of the lung. And anyway, with patients with or without pulmonary AVMs, as you know, most of you here know that clinic follow-up is important. It's not just the lungs, it's a multi-system assessment. Genetics when appropriate, as we've talked about, screening other family members is part and parcel. And here we have an EMR system called EPIC. So we have beautiful pedigrees we can create with family members just in the last year. Dedicated follow-up for pulmonary AVMs is particularly important. We try to say yearly review. Telehealth, we in Alberta do a lot of telehealth. Alberta Health Services has been doing this for 20 years. And we actually were one of the first to start doing respiratory telehealth. And in the US, they called on us to, if you're interested, to talk about the different aspects of e-health and specifically telehealth, which for a rural, remote population, those in the territories, Northern Alberta, Northern BC, we see a lot of patients from up there. It's very important because they can't drive down on the winter roads half of the year. So yearly review in some form. Bubble echo can remain positive. We say 100%, some may be negative, but we tell patients if you're positive once, you should remain on PAVM precautions, which involves, as Richard mentioned, because when we do dental cleaning and other dirty procedures, you can introduce bacteria into the blood. So we want to have patients aware that they need to ask for antibiotic prophylaxis to the dentist, dental surgeons, and other procedures they're going to let them know. Eliminating air emboli inadvertently, so using air eliminating IV filters. Not all IV filters are air eliminating. And also when you get blood draws, using a vacutamer or vacuum suction device to remove the blood, or a lab tech or a lab that has more expertise, especially if someone lives peripherally, we just say use a vacutainer and teach them what that means as part of our teaching regimen in the clinic. All of those are important and reviewed, just like in asthma, chronic disease management. We call this PAVM, chronic disease management, to make sure patients are aware, reminded of it at least once a year. Richard, is this your one? I think?
Yeah, I think it's just another quick case. So we'll do this quickly for the interest of time. So this patient has a very large PAVM, and it was detected on a routine chest X-ray. But in fact, he presented when he was young with a stroke, but this was in the days before. I think we treated him when he was 60 or something. So this is when he was in his 20s. So the HHT Foundation and all these things were not really around in those days. But if you move on, you can show what he had. And then this is, you know, you can't see the blood vessels like that on a chest X-ray, but you can see that blob. You know, that is easy to see. And that would have been, even if it had been noted in those days, would have been treated with a lung resection. They would have removed probably the whole upper lobe, I think. And that would have been an effective treatment in the day is all they had. But in this case, you know, we went on to embolize. You can see the next slide. This is the one actually with the biggest one I've ever treated. So you can see, I think, how big it is relative to the catheter, because it's not, I haven't had to enlarge it. But again, that Amplatzer plug that we used was very effective. We used two next to each other to stop the flow. And you can see, you know, that really we haven't lost a lot of lung, which is great. And then, so yeah, so that was him. It's a great device for those patients. It's really all there is to use in those very high flow situations. And then this is a different case. Do you want me to go through this? Or
I think for time, we probably should skip over this case.
Yeah. So go ahead, just, yeah.
Questions, yeah.
So you go ahead. I think you're on.
I think it's almost the end to just say, we've been able to develop satellite centers within Alberta, North Zone, which is Grand Prairie, and Fort McMurray. We've been working hard at, especially during COVID, to get general internists there with respiratory expertise, and that's come along nicely. I'm still struggling with Red Deer for different reasons. As you will see tomorrow, Charlene Fell has been the satellite site center director for many years now, and Dawn Goodyear, who's a hematologist, works closely with her and our IR team there. And we're just developing the South Zone as a satellite center. So patients don't have to travel. As I mentioned, it's very hard in wintertime in particular. I hear that a lot. So this is important to make sure patients receive a lot of their regular care with specialists who know and are very familiar with HHT or develop that expertise over time. Cranbrook and Kelowna for interior health is just developing. The last 5 years, I've worked with a lady named Lori Wick there. So things like pregnancy, iron management, all of that, if we can do it in their health region, particularly in Canada, that's important instead of traveling to different provinces, quaternary care centers. Vancouver, as you'll see tomorrow, as well as Scott and Pierce Wilcox before. I work a lot with both of them, with patients and often family members who go back and forth. And Prince George in northern BC, north of the mountain range, many patients will not go to BC or to Vancouver. They'll go to either Grand Prairie or Edmonton. And so how we organize care in Western Canada, probably quite different in the Atlantic provinces too, but the distances are huge. And that's important to consider when we look at delivery of care, the regular follow-up.